and welcome to the Better Medicare Alliance's Rate Notice Crash Course Briefing. Thanks so much for joining us this afternoon. I'm Mary Beth Donahue, President and CEO of the Better Medicare Alliance. And as many of you know, we are finding ourselves in the middle of rate notice season right now, the annual period in which CMS issues payment policies for Medicare Advantage and Medicare Part D. And as you know, CMS had issued the advance notice last week, and over the coming weeks, the agency will be looking for feedback as they issue the final rate notice by April 4th. And these are really important policy decisions that are going to impact the over 28 million seniors and individuals enrolled in Medicare Advantage today and those expected to enroll in the following year. If you've attended our webinars and events in the past, you always hear from us on what's at stake, and then more importantly, how we drill down into what is behind the technical language and how it impacts the beneficiaries. Before we get started, though, I do want to just sort of set the table with a few quick MA facts. Seniors today voluntarily choose Medicare Advantage. This is the coverage option that they selected, and they give it a 94% satisfaction rate. Also, Medicare Advantage beneficiaries are proportionately more diverse, lower income, and possess higher rates of social risk factors than beneficiaries in Medicare, meaning that our most vulnerable seniors are the ones who are most impacted by these changes in Medicare Advantage funding. And last, Medicare Advantage beneficiaries have lower rates of avoidable hospitalizations and readmissions, and higher rates of preventive care and screenings, all while saving an average of $1,640 a year compared to fee-for-service. Now, the good news. The advance notice that CMS just delivered last week takes important strides to protect these beneficiaries' coverage and gives seniors stability and predictability into 2023. In a few moments, you'll hear a very fact-based analysis of the advance rate notice from our friend Matt Kazan, principal at Avalere Health. But let me share BMA's view on behalf of our allies and grassroots advocates, that this advance rate notice protects coverage choices, advances health equity, a mutual goal that we at BMA have with CMS and the administration, and preserves affordability for our nation's seniors. And we appreciate these proposals announced in the advance rate notice by CMS. We're committed to ensuring that these protections for beneficiaries are upheld in the final notice. And we look forward to continuing to work with CMS and others to ensure that all of us are doing right by the seniors and individuals with disabilities who put their trust in Medicare Advantage today. Now, let me turn it over to the experts. I'm pleased to introduce my colleague, Greg Geer, Vice President of Policy and Research here at BMA, and Greg will also introduce Matt. Thank you, Greg, and thanks in advance, Matt.
Thank you, Mary Beth, and welcome to today's webinar. We are very fortunate to have back with us today Matt Kazan. He's a principal at Avalere Health, which is one of the nation's premier health policy and consulting firms that advise clients in navigating the ever-changing and complex legislative and regulatory environment. Prior to joining Avalere, Matt served on the Senate Finance Committee for over a decade under former Senator Max Baucus and current Senate Finance Committee Chair Ron Wyden. As Senior Health Policy Advisor, Matt was the primary policy advisor on healthcare policy issues, including Medicare Advantage and Medicare Part D. And during his tenure, Matt was involved in a number of landmark legislative efforts, including the Affordable Care Act, the Bipartisan Budget Act of 2018, the Children's Health Insurance Program Reauthorization Act, and the American Recovery and Reinvestment Act. Matt holds an undergraduate degree from the University of Denver and has a master's in public policy from the George Washington University in DC. Matt is going to provide an in-depth review of the major provisions and elements of the advance notice, as well as shares insights and perspective on the impact on Medicare Advantage. As Mary Beth mentioned, this rate notice season that we're in is really critically important, with policies being considered by CMS that have potentially far-reaching implications for both Medicare Advantage and the over 28 million beneficiaries who rely on it. So the release of the advance notice, coupled with the release of the proposed rule last month, marks an important milestone in the policy and rate setting process, and really represents the first major rate notice developed entirely under the Biden administration. So to that end, what it does is provide an opportunity for the administration and CMS to really shape the program as the administration looks to advance important policy work on shared goals, including advancing health equity, improving the beneficiary experience, lowering out-of-pocket costs, and improving quality of care and health outcomes. After Matt's formal presentation, as always, there'll be an opportunity to ask questions and offer comments as organizations continue to really dig into the details of this important rate notice. So with that introduction, I'm happy to turn it over to Matt.
Thank you so much, Greg, and thank you, Mary Beth, and thank you, BMA and its allies for the invitation to speak today on an overview of the 2023 advanced rate notice. So, let's dive in and if we advance one more slide, a little bit of kind of level setting, right? We've got a lot of activity going on as it relates to Medicare Advantage, as Mary Beth and Greg noted, right? We've discussed previously the proposed rule that came out a couple of weeks ago, where comments are due on March 7th. That regulatory vehicle really establishes changes in policies to MA and Part D that require changes to federal regulation. The advance notice, which we're talking about today, is really the regulatory vehicle that CMS uses to make changes to payments to plans, whether it's in Medicare Advantage or Part D, as well as some other kind of policy-related issues that we will dive into. Comments on the rate notice are due three days earlier on March 4th, and per statutes, the final rate notice is expected to be released on April 4th. So a busy couple weeks between now and the beginning of April for folks involved in the Medicare Advantage program. So let's dive into what we saw in the advance notice that CMS released last week. So the biggest piece on the advance notice, right, is the changes in the MA rates or the MA benchmarks year over year. And there's a whole host of different components that go into those overall rates. But as you can see from this slide, Medicare Advantage rates are expected to increase by about 4.5% in 2023 compared to 2022. Most of that change is due to what's known as the growth rate, right? MA payment is linked to fee-for-service spending and trends in fee-for-service spending. And so each year CMS looks at past fee-for-service spending and projects fee-for-service spending going into the future and comes up with this growth rate percentage. And you'll see in 2023, that number is 4.75%. But there's other components of the rate, as this chart notes, right? Star ratings affect MA payments. CMS expects a slight payment increase due to changes in star ratings, as well as a slight payment decrease due to what's known as normalization, which we'll get into. That relates to changes in risk scores for MA plans. But overall picture, as you can see, compared to previous years, a little bit higher payment increase than we saw in 2022, substantially higher payment increase than we saw in 2021. And so obviously, from an MA program standpoint, positive news on the overall payment change. But there's a host of different kind of policy details that go into these. So let's spend some time on some of the more notable ones in the notice, as well as some areas that CMS is looking for stakeholder feedback for potential future policy changes. So summarizing what's in the notice versus what's not in the notice, on the left-hand side of the screen, a host of different policies, as I talked about, changes to the methodology around normalization, changes as it relates to Medicare Advantage and patients with kidney failure or ESRD, some slight changes on the Part D risk score model that we can talk about, and then a bunch of changes and discussion around social determinants of health, social risk factors as it relates to MA star ratings, quality measures, and the risk model. Notably, what is not discussed or proposed in, or changes are made in the advance notice, kind of two big highlights. There are no major changes to the overall CMS risk model, and there is no increase in the coding intensity factor. This is that kind of across the board adjustment that would reduce plan payments and plan risk scores. CMS does not propose to make any changes on that front. And so just as important to know what's in the advance notice, it's also important to know what CMS chose not to put forward. So that's notable as well. But we'll spend some time here on some of these policies on the left-hand side of the screen. So the first big one that you saw from the original chart was, a really technical one, but an important one as it relates to what's known as normalization. I won't get into the weedy details, but essentially CMS tries to ensure through the MA risk model that a person who's kind of designated as having an average health status, it's often referred to as someone with a risk score of 1.0, looks and feels like the same, whether they're in fee-for-service or in Medicare Advantage. And they have to make some kind of methodological and math-related changes to ensure that that happens. And so what they're doing with 2023 is they're taking into account the fact that this would be the first year where they would take data from 2020, which of course was during the first year of the COVID pandemic, and they're excluding that data because they saw in that data a real drop in utilization and a real drop in risk scores due to the pandemic. And BMA has done a lot of good work on this issue and has produced some studies on that for folks that are interested in taking a look at that. But because of this kind of outlier in terms of a year where we saw risk score drop, they're excluding that data from normalization. And that has a potential impact of a slight payment decrease overall to MA plans. But as that original chart illustrated, not a huge decrease in plan payments, and certainly smaller than what we've seen in previous years. But you'll hear about it. CMS does spend some time talking about it, its justification to do that in the advance notice. So worth highlighting on this first slide here. So if we advance to some of the other policies in the notice, CMS does spend a lot of time and discussion around a couple of different issues as it relates to people with kidney failure or end-stage renal disease who are enrolled in the Medicare Advantage program. One change that they are making is on the risk adjustment model for ESRD patients. There's a separate risk adjustment model for this particular patient type because of their complexity, because of the different costs associated with them. CMS keeps that risk adjustment model separate than the standard kind of aged disabled risk model. So CMS is proposing to make a couple of different changes here. Updating the model based on clinical factors. They're updating the years in which the data takes effect. And they're also updating the model to try to align with what they did a couple years ago with the standard risk model, trying to differentiate the risk models based on, are you a dual? Are you a partial dual? Are you a full benefit dual? In CMS's attempt to try to make the risk model more accurate. And so they're pulling some of those changes over here to the ESRD risk model. It can seem technical, but there is a meaningful impact to these changes. CMS does estimate that this is going to reduce MA payments by a little less than $500 million in 2023. So a significant amount of money overall to the program, but maybe more importantly, it will vary tremendously by plan, depending on your ESRD enrollment, as well as the characteristics of those ESRD patients. Are they duals? Are they partial duals, full benefit duals, not duals at all, et cetera. So something to dig into if you are particularly invested or interested in this space, and is a proposal that, as it stands now, would take effect for plan year 2023. There's a separate ESRD issue where CMS is not proposing to make any changes. If we advance to the next slide, but they are seeking comment. And this is one area where BMA has been pretty active and has put out some excellent studies that have been cited by MedPAC, by CMS, and by others. And so wanted to spend a little bit of time on this issue. As folks may recall, the 21st Century Cures Act, which was passed by Congress several years ago, had a provision in it that said all ESRD patients can enroll in Medicare Advantage starting in 2021. Whereas before that, you were not allowed to enroll in Medicare Advantage if you had ESRD, yet you had to stay in fee-for-service. If you had it while you were already in a plan, you could stay in your plan, but you couldn't actively choose a Medicare Advantage plan. And so that has changed starting in 2021. And because of that change, a lot of stakeholders have thought about should the methodology for how CMS pays Medicare Advantage plans for these patients change as well. The payment methodology and the way in which CMS calculates these payments is very different than how CMS calculates payments for kind of your standard aged beneficiary in Medicare Advantage. The rates are set at a statewide level, and that's one of the real big changes. And so BMA with Avalere conducted an analysis a couple years ago that looked at the payment rates in areas of the country where there's a lot of ESRD beneficiaries and compared those payment rates to the actual costs of ESRD patients in those markets. And as you can see from this slide, a lot of areas of the country, the payment rates were well below those actual fee-for-service costs of patients with ESRD. And so some stakeholders have taken a look at data like this and other similar studies and said, maybe the statewide payment rate doesn't make a whole lot of sense. Should we base those payment rates at a smaller geographic area? And really for the first time, CMS publicly in the advance notice talked about whether or not they should do that. And they said they conducted a study to take a look at what the payment rates would look like if you were to do set the rates at a CBSA level, kind of metro area levels. And their analysis found, they say, that rural rates would decrease by about 2.6%, but urban rates would increase by about 0.5% rate. So given the kind of uncertainty if that is the correct policy from CMS's standpoint, they decided not to propose an actual change, but are really seeking comment from stakeholders about this issue, whether the CBSA issue payment change is the right one. Are there other policy considerations that they need to take into account to ensure kind of payment accuracy in the areas in which there are ESRD beneficiaries? So an important topic that folks should take a look at, and also a topic where BMA has been very active in the past here. So if we advance to the next slide, we'll ping around a little bit here in terms of topics, but to kind of keep the theme of risk model changes. On the Part D side, CMS is proposing kind of modest changes on the Part D risk model, as well as updating the kind of basic benefit parameters of the Part D program, right? Where does the deductible sit? Where does the coverage gap sit? Where does the out-of-pocket threshold sit? Those dollar numbers are updated every year. And as you can see, they are noted on this slide here. So that's important from a beneficiary standpoint of how much do I need to spend to hit my deductible? How much do I need to spend to hit the catastrophic threshold, et cetera. And so you could find those in the advance notice, as well as CMS is proposing some kind of, as I said, modest updates to the Part D risk model. I think we go into some of the specifics on those models in subsequent slides. So let's advance one more. One big theme of the Part D risk models was really kind of splitting out the categories of conditions and diagnoses from kind of groupings to a little bit more granular groupings. And so you can see here in this slide, and I believe also on the next slide, some very kind of condition-specific changes that CMS is proposing. So while the model changes may be modest generally, certainly if stakeholders have an interest in these particular conditions, diagnoses, patient types, it's worth taking a closer look at the model and seeing if there's any effects or comments that you'd like to submit to CMS before that March 4th deadline. So we list these conditions here, as well as on the next slide, you'll note CMS is adding certain diagnoses and conditions to the risk model, as well as removing some conditions to the risk model. So anyone interested in really wonking out on the Part D risk model, I'm always game, and I'm sure others are too. So we can table that conversation for another time, but definitely wanted to call out these particular disease-specific changes here. So if we go to the next big theme of changes that CMS talked about, there was a lot of discussion around quality, star ratings, and social risk factors, social determinants of health. And so CMS is really doing a mix of two things. They are proposing some changes in the advance notice, but in a whole bunch of areas, they're soliciting feedback for future policy making. And so we threw up a couple of different kind of areas in which they're seeking comment or proposing changes. Adult vaccine immunization status, CMS is looking to potential changes or improvements about how we measure that and how that's noted in the star rating system. CMS is contemplating changes around complaints by beneficiaries about MA plans or Part D plans. We saw this as a little bit of a theme in the proposed rule around marketing, and they're carrying that through here on a star rating measure as well as contemplating changes to the parameters around colorectal cancer screening and the age of beneficiaries that are part of that measure. But a big theme, is, as I said, right, is around health equity, social risk factors. And so CMS discussed a whole lot of potential changes that they could make around specific star measures and how much they're focused on improving health equity, as well as the type of data and other inputs that CMS may need to really better measure health equity and how individual MA plans are tackling that particular issue. And so if we go to the next slide, I think we dive down a little bit deeper on that particular issue. This is an area where CMS is responding or is asking for stakeholders to respond in a lot of different comments. And so if you're interested in this issue, if you're invested in health equity, social risk factors, this is an area of the advance notice that you want to go over really with a fine-tooth comb and find all those areas where they're asking for comment and think about what information you could provide to the agency, because this clearly is something that they're thinking about very closely. A couple areas that they're focusing on in particular in the advance notice, they're looking at, are there certain kind of groups of measures that social risk factors influence, and can we stratify contracts across those measures to try to judge how plans are doing on some of these important quality measures. They are focusing on health risk assessments, and this does intersect with something that was in the proposed rule around requiring plans to ask certain questions about the availability of beneficiaries' kind of transportation, nutrition needs, housing needs, et cetera. So whether or not there needs to be further changes on the quality front in that respect. And then they're asking for feedback around the accuracy of CAHPS scores and submissions, which we know some of the questions do touch on some of these overarching issues as well. So for folks very much focused on quality, for folks very much focused on equity, this is certainly an area that go back, read, and take careful note of what CMS is thinking about here or potentially in the future. Similar theme, but a different kind of policy lever is around the risk model, right? As I said earlier, CMS is not proposing any major changes to the standard Medicare Advantage risk model. But what they are doing is seeking comment on changes to the risk model that's going to better reflect these social risk factors or social determinants of health in potential future policy making. So under the current model, the inputs that CMS uses, demographic information about beneficiaries, right? Age, dual status, as well as diagnoses. What conditions does the patient have? Then the risk model calculates a potential risk score that is supposed to predict the potential cost or future cost of that beneficiary. But we know that there are other factors from literature and other studies that impact how much medical spend a beneficiary has. Some of those are related to social risk factors. And so CMS is looking at, is there other types of data that we could put in the model, say zip code data or other kind of data that would measure the level of social risk factors that are present? And could those be incorporated into the risk model and affect plan payment to try to better accurately reflect payment going to those Medicare Advantage plans that have enrollment in these particular spaces? So again, something to consider in terms of your comments for that March 4th deadline. So if we go one more slide, those are really the big highlights in terms of the policies that are in there. I'm happy to take questions. I'm sure Greg's happy to take questions as well on some of the key details and BMA's stance. Couple of key dates to be aware, because there's a lot going on in the Medicare Advantage space. Obviously, we had the proposed rule come out. The advance notice came out. Comments on the advance notice, as I said, are due March 4th. 3 days later, those comments on the proposed rule are due on March 7th. By statute, the final rate notice needs to be out by April 4th. There is not a statutory requirement of when the proposed rule needs to be finalized, but we would expect it to be finalized sometime around when the rate notice is finalized as well, so that plans have enough time to create and submit their bids, which are due on June 7th. And then, of course, beneficiaries are able to begin to enroll in Medicare Advantage plans for 2023, starting in October of this year through the open enrollment period, which finalizes in December 7th, so that folks are ready to have their coverage be effective for January 1st, 2023. So as Mary Beth said, we're in the busy season here, and a lot of stuff going on. So I was very fortunate to be able to speak to you all today, and happy to answer any questions about any of these topics.
Matt, we do have a question that just came to us in the chat box. Jenny asks, what are your thoughts on the next few advance notices and what CMS will do about pandemic year risk scores, seeing as they did not include 2021 risk scores for the normalization factor?
It's a really good question. I think assuming that CMS finalizes what they proposed on normalization, right, this will be an issue that will keep coming up year over year, because that normalization factor really relies on kind of a rolling set of data. So they'll have to make the decision every year whether or not they're going to exempt 2020. They're also going to have to take a look at, risk scores and utilization experience in 2021 that will affect 2022 risk scores, to see if this issue plays out beyond that 2020 pandemic year. So that's something that they're going to have to think about, and something worth watching. The other issue worth watching in this space, right, is during the pandemic, CMS allowed plans a little bit more flexibility on collecting diagnoses for risk score purposes via telehealth. If there was audio and visual telehealth, that was a flexibility that wasn't really directly linked to the public health emergency, but certainly was done within the context of COVID. And so, no indications at this point that CMS is thinking about, rolling back that policy, but certainly something to keep an eye on as the health system writ large kind of gravitates more towards telehealth. And as new variants potentially come out, or the experience we saw with Omicron, there still is some hesitancy of some individuals to go to the physician office or health system and would prefer telehealth. So those two issues in particular are something that I think in future notices we'll have to keep a close eye on.
Thanks, Matt. We've got another question here from Grace, who asks, is it fair to read CMS's risk score comments as sort of accepting that an across-the-board coding intensity adjustment increase probably isn't the solution?
I hesitate to speak to kind of the intent of CMS, right? I think it is clear, right? They have the statutory authority to increase coding intensity. There is an across-the-board coding intensity adjustment today mandated by Congress. CMS has the authority to make a higher adjustment than what CMS or what Congress has mandated. But I think in every year, CMS has said, we're only going to do the minimum and not increase it. In previous notices, CMS has solicited comment on alternative policy structures to that coding intensity, right? Having a more targeted adjustment where the adjustment is higher for some contracts and lower for other contracts. But CMS has not really pursued those policies in any meaningful way, rather than just soliciting comment. And in this rate notice, right, they just proposed a policy that would keep the status quo as it relates to the coding intensity. So that's how I'll answer the CMS intent question there.
Great. We've got a question from Lauren, who says, thanks for the great info, Matt. You had a 3.45% average risk score trend in your slide for 2022. CMS didn't include this in its fact sheet on estimated rates for 2022. where can that figure be found?
That's a good question. I don't believe CMS provided that number for plan year 2022. And that's really an estimate of what CMS thinks is going to happen in future years, right, as it relates to risk score growth year over year. And so generally when CMS has put that out, they're nice round numbers. It's not as precise as some of these other numbers like growth rates. And so I think we may have to wait a little bit longer to see if CMS or other academics put out kind of an actual risk score growth rate over time from 2022 to 2023. But Lauren, I don't think you're going to be able to find that number very easily because I don't think CMS provided it to the public in their notice for the 2022 plan year.
We've got another question here that says, why didn't CMS release an early preview notice for 2023 rates as they have done in past years?
Yeah, that's a very good question. I do not know. I would direct that question to CMS. I'm unclear why they didn't do that this time.
We've got a question from Latoya, who says, what implication will the rate notice have on the risk adjustment policy update expected later this year?
Latoya, if you could put back in the chat kind of a little bit more specifics about the policy update you're expecting next year that you're referring to, that would be very helpful.
We have no additional questions in the queue at this time.
And Latoya, happy to follow up after the webinar as well.
Jonathan, I'm happy to jump in. I do have a question and appreciate the terrific questions that have been raised. And maybe this will also give Latoya an opportunity to either follow up with Matt separately or go back to the chat room, or Greg, I don't know if you might know what she's referring to. But in the notice, advance notice, Matt, there's lots of policy changes, and CMS offers the interest in soliciting input from those who will submit comments, and many of those organizations are on this webinar. What advice can you give organizations when the regulatory agency is looking to solicit their input?
Yeah, I think the first advice is take them up on that, right? I think there is a potential pitfall in looking at this notice or other regulatory vehicles that are really soliciting comment in a number of areas, but in those areas they're not actually proposing a tangible change. I think it would be a mistake to not take up CMS on that opportunity to submit your comments, because frankly in regulatory changes and legislative changes, it's often much easier to influence the process before the writing's on the piece of paper, right? Whereas if you wait until next year's notice or next year's proposed rule, where CMS has kind of a defined proposed policy, maybe they're open to tweaks around the edges, but it's going to be really hard to influence it, as opposed to probably where they're at the stage in many areas here, where they don't have a formed policy proposal fully fleshed out, right? And they're truly seeking input from stakeholders to do that, and kind of getting yourself on the ground floor in terms of influencing that process, I think in many ways could be much more impactful than waiting for that tangible policy proposal that's submitted by CMS. Then you have 30 days to comment or 60 days to comment next year around. It's a lot harder to do. So I know there's a lot of areas in which they're seeking input, so you may have to pick and choose your battles there. But I definitely think it's worth submitting those comments and where you think there are impactful areas or potential changes.
We've got a question from Ashley here, who does identify herself as a reporter, but she asks, regarding the quote expected change in revenue for 2023 being at nearly 8%, that means the increase in how much the government would pay to insurers, correct? That does not mean an increase of 8% in costs for consumers. Is that correct?
Yes, Ashley, I think that's generally correct, right? So I think the 8% number is a function of two numbers, right? It is partially on that first slide that I put out, the change in the benchmarks that MA plans are bidding against. And then there is a separate part of that number that CMS put out as an estimate of how much they expect risk scores to grow year over year. And right, I think the number that CMS put out was just south of 8%. But what beneficiaries pay is really a function of a bunch of different factors related to MA plan bids, MA benefit design, and obviously utilization of the beneficiaries. So that's a little bit more complicated, and you probably can't make a apples to apples, 8% here to 8% there in terms of consumer out-of-pocket cost increases.
Terrific. Well, Matt, thank you so much, and really appreciate the questions from those attending the webinar. And again, thank you, Greg. Thanks, Matt. And just thank you for everyone joining us this afternoon. Before we close, I did want to just do a reminder to encourage those of you who could be joining the webinar from any of the Senate offices to consider taking a simple action to show support for Medicare Advantage beneficiaries in your district. And again, as a reminder, 1 and 2 beneficiaries choose Medicare by choice, and that is their choice that they're given. And right now, we have leadership in the Senate, bipartisan members of the Senate who are leading an annual Medicare Advantage support letter to the Biden administration. And it's a straightforward letter that's sent each year, and it simply affirms support for the option of Medicare Advantage and encourages continued stability for the program. And any member of the Senate can sign. This is a letter that's being led by Senators Catherine Cortez Masto and Tim Scott, and it'll close for signatures by the end of the week. And right now on this slide, we're showing you the contact information for those healthcare staffers who are kindly organizing the signing on this letter. Please feel free to reach out to them. And I do want to remind those who had not heard that this letter would serve as a companion letter to a recent bipartisan House letter that was led by several members of Congress, Congressman Brett Guthrie of Kentucky, Tony Cardenas of California, Earl Blumenauer of Oregon, and Mike Kelly of Pennsylvania. 2 Republicans, 2 Democrats, and they gathered 346 signatures, 80% of the US House, and that's a new bipartisan record. So with your support in the Senate, we're very optimistic that we'll achieve a new record in the Senate as well. So with that, I just want to thank you all from the Better Medicare Alliance for joining us. Please use us as a resource for you, your colleagues, and those in your community, and in any understanding of Medicare Advantage. We want to be able to be here to equip you with the facts and research to help advocate for your constituents so they can rely on MA coverage that they're choosing and that they feel they need and deserve. And I just want to highlight our website, www.bettermedicarealliance.org. Please turn to it for our latest reports and fact sheets, some of which you heard Matt reference during the webinar. And I just again want to look forward to saying thank you, and we'll see you all again soon.